So with this high level of prevalence of psychiatric comorbidity, then the question is, well, why aren't these kids already being identified? Because most of them actually hadn't been identified. Well, this is not a unique problem to us. It's a problem all over the place. And there's two concepts that I think are part of the reason why it's hard, or why it is sometimes challenging to identify mental health or psychiatric disorders in kids with developmental disabilities broadly. And the two are, I mean, one is the concept of diagnostic overshadowing. I spend a lot of time with families when I give diagnoses of anything, but including autism, of really trying to be clear with them that this is a double-edged sword. Not only are there some clear advantages in terms of what we are going to be able to use or access, but also in terms of informing what we do, but there is a tendency for all humans to look at big label diagnoses as describing more than they really mean to. So if you have a big label diagnosis like autism or an intellectual disability, it is very likely that people will ascribe any new problems that they see up to that primary diagnosis. Why can't Johnny sit? Well, he has autism. That's why he can't sit. Why is Johnny so afraid of going into the presentation hall? Well, of course he has autism. He's not comfortable with people. And there's this tendency to ascribe up to this big label diagnosis. And so it has it creates a problem, because if that's what you're doing, what you're ending up doing is missing out on identifying the things that are causing the difficulties. The second part of the problem is this idea of entanglement, is that the symptoms of kids of anxiety, of ADHD, of tics, of mood disorders in kids with autism don't present in the same way as they're described in the DSM. Or in other textbooks for that matter. And the reason they're not described in the same way is because we don't have neurotypical kids we're talking about. And so through this neuroatypical lens, the symptoms get distorted and they change. And they don't look the same as the ones that we might have seen elsewhere. Now, another reason I think that it becomes really complex is this complex table, which is the degree of complexity to the comorbidity. Now, I want you to focus only first on the top line, the total line. So this is our familiar 580 kids that we've been talking about. Now, of this 580 kids, 38% of them had one psychiatric comorbid diagnosis. 38%, an additional 38% of them actually had two psychiatric comorbid diagnoses, and 12% of them had three psychiatric diagnoses. Now, to give you what that looks like, so with three, you have a child who's been referred, who has ADHD, anxiety disorder, and a tic disorder. Not just one of the three, but all three. The other thing that this table shows us is why the 67% was being referred. They're actually more complicated than the kids with autism. And what you see here is the burden of mental illness in the bottom line here. The kids who do not have autism is higher. Psychiatric, 41% as opposed to 32% have one psychiatric diagnosis, 43 as opposed to 27 have two psychiatric diagnoses, and more have three or more. So it helped us understand, and it makes sense now that we look at it. It's like, okay, the reason why these kids are being referred and they're not autistic is because they have these complex neuropsychiatric profiles, and the people wonder what's going on. And they don't have autism, but they have this other huge burden of illness. Just so that you know that this was not just us discovering this. Similar sorts of studies have come out since then elsewhere, which have indicated again that these complex comorbidities, these multiple psychiatric comorbidities, are part and parcel of what we see in longitudinal follow-up with kids who have autism spectrum disorder. Okay, questions or comments about that? Yes? The question was, am I looking at family history of psychiatric disorders?
Yes. So how many of these children had a history of family
So the question was, how many of these children had family history of psychiatric? I don't have that data. I don't have that information. I would suspect, just based on what we know about all of these things, is that apples don't fall far from trees, and that there's always going to be familial components to anxiety, ADHD, autism, all these things. We don't understand the genetics nearly well enough to be able to separate things out, but I would say that it would be it would be a pretty common event to have a family history of something. Okay, so with those concepts in mind, let's go back and say, well, why are this is really a complicated endeavor. It's all entangled with other symptoms, and, it's kind of hard to differentiate. Wouldn't it just be easier just to call this kid autism and just kind of go forward and not kind of try to break this all apart? And then we know what to do. Well, the relevance is this, is that there's lots of evidence, increasing evidence, that untreated psychiatric syndromes in the context of an ID, intellectual disability, and or an autism spectrum disorder creates difficulties for a variety of reasons. One is it confounds diagnosis. It makes it very difficult to know exactly what you're dealing with. But even more so, even if you go beyond the boundaries of what is needed for diagnosis, it affects the individual's ability to effectively use developmental interventions that have been researched and tested and really, we know, work. So, an example, a kid with profound ADHD as well as autism who needs a discrete trial ABA format type of intervention but can't sit because they have ADHD, will not be able to take advantage of the ABA because they can't sit. Or the child with selective mutism, who also has autism, but and needs to do some work in either a social communication group or even in one-to-one speech and language therapy, because most of these selective mute kids, as you well know, also have language problems going along with it. But they go into the SLP's office and you're not going to get much better if you're not talking or practicing it. So the impact of the psychiatric syndrome has a direct impact on the developmental syndrome. And if you don't address the psychiatric syndrome, you might not even be able to get in the door to address the developmental issues. The other concept is this idea of a full plate. As you know, these are kids with a lot on their plate. Right? They have developmental problems. Now we've given them another diagnosis of autism, and we find out that they have ADHD and anxiety. This plate, which was already kind of full to the brim, is starting to spill over. But there are things that we now have tools to actually take things off the plate. We can spoon things off. We can take some ADHD off the plate. We can take some anxiety off the plate, and guess what happens? Things are not spilling over anymore. So this idea that in a typical kid, the same level of symptoms might not actually have that much impact, or as great of an impact, I should say, because there's more room on the plate. But when you've already got all the stuff going on, even a relatively milder syndrome can have a much greater impact because there's less flexibility in the system.